This is Professor Michael Chapman. I'm one of the most experienced IVF doctors in Australia. I believe that an important part that I can contribute is to educate patients in relation to fertility, infertility, and all that involves. These series of podcasts help to educate you. I hope they are helpful to you. If you wish to know more, however, I'm more than happy to have you contact me via email, which is profmchapman@gmail.com, or make an appointment to see me on 9138 4222.
What are certain issues that could impact implantation with frozen 5-day embryos?
Unfortunately, I get asked that question probably in my 2 clinics a week at least 5 times, because when a frozen embryo is put back, at best, it's a 40% chance of producing a pregnancy. In other words, 60% of patients will be sitting in front of me asking exactly the question that you're asking. And I take a big breath in. Obviously, I have an approach to this problem to hopefully make patients understand a little bit about what's going on, but then I have to confess there's a lot we don't know. So we start with the embryo. Was it a normal embryo? Genetically normal embryos have a higher chance of producing a pregnancy. When we genetically test embryos and put one back, it jumps from around 35 to 40% to 55 to 60% chance of producing a pregnancy. So a significant percentage of failed transfers are because the embryo was actually not genetically normal and nature's done its job of not letting those implant. Then we go to the environment that the embryo is going into. So is the lining of the womb healthy? Or 2 things, is it healthy and is it at the right time of the cycle? With the healthiness, in patients who have repeated failed implantation, around about 1 to 2 in 100 will have chronic infection of the lining of the womb called endometritis, which will reduce the chances of a pregnancy. That can be tested by doing a scrape of the lining of the womb, but that does require an operation. The alternative management of that is to just treat it with the antibiotics that would be given should we find an abnormality like endometritis in the first 2 weeks of the menstrual cycle, the treatment cycle, and avoid the operation. The next is the timing. So an embryo in nature arrives in the uterus 5 days after ovulation. It spends most of that time in the fallopian tube where fertilization has occurred, and then it comes down into the uterus around day 5. And that's when the hormones, the structure of the lining of the womb, optimize the timing, the structure for implantation to occur. So when we put an embryo back artificially, we want to be sure that lining is in synchrony as it would be in nature. And there is a small group of patients in whom that probably isn't the case, where progesterone levels aren't as high as they should be, or possibly there is a basic problem with the lining of the womb. These days, what we tend to do is to supplement the progesterone in a frozen embryo cycle. Not everyone, but certainly I do in any woman over 35, just because we know that there are deficient progesterone levels from time to time in older women. So that lining of the womb is important. There are some tests that people have commercialized to look at that synchrony. I think, no, in fact, the big randomized studies have shown they actually don't make any difference. The next, we could go back one. One of the things that we're increasingly doing is looking at is measuring the progesterone levels on the day before we do a transfer to make sure that they're at high good levels. And I think that's become more and more convinced that's useful to do. And we either stop the transfer if it's very low, or if it's marginal, we add extra progesterone for the next 24 hours. Again, the evidence that makes any difference in randomized studies has yet to be proven. And then we go to things, environmental factors outside of the uterus that may play a part. One is immune responsiveness, and although that happens in the womb, it may be a more systemic problem. There's something called antiphospholipid syndrome, And in that situation, if we found that and there were tests to do to test that, we would give steroids to suppress that activity. NK cells may be part of that investigation, but as I said earlier, I'm not convinced. Other theoretical things, tendency towards blood clotting, because that embryo has to establish a link, a vascular link between the mother and the placenta. And if there's a blood clotting tendency, maybe that blocks up the little blood vessels and causes a problem. I was at a lecture only 2 weeks ago where an eminent professor from the United Kingdom was very negative about that as an approach, because his argument was that, in fact, that vascular really doesn't happen until 8 or 9 weeks of pregnancy, so how can it be related to implantation at the very early stages? We measure thyroid hormone, but again, there's no real evidence that hypo or hyperthyroidism makes a particular difference to implantation. You can do all those tests, look at all those things, and what do we find? Less than 5% of patients who don't get implantation with an embryo show anything that we can think about treating or be abnormal. We generally, the one thing I talked about, genetic testing to at least put back an embryo that's a normal karyotype will improve the chances of success, but there's still 40% of women after putting back a euploid embryo who will not be pregnant, and we will have this conversation once again.
And don't forget that you can access all the previous episodes by going to our website www.theivfjourney.com and select IVF Journey podcast from the navigation menu.